Hello, good afternoon. Welcome to this Post-Cardiotomy webinar from the EuroELSO. Nice of you to join us. We have a wonderful program with speakers from mainly Italy, moderators, but luckily from some other countries in Europe as well. We hope to provide you with a program showing you the different aspects concerning post-cardiotomy ECMO. We will be recording this webinar and it will be available to look back on the EuroELSO website and also on the YouTube channel next week. We will have presentations and discussions from 3 speakers we found on this topic, and that will be Silvia Mariani, who is a cardiac surgeon at the University of Monza, and she just finished her PhD on post-cardiotomy ECMO. And if you look up her thesis, there are lots of chapters on post-cardiotomy, also with lots of data put in by people who work at ELSO centers. The second speaker will be Schaefer. She's also a cardiac surgeon working at the Medical University in Vienna. And the third participant will be Fabio Sangalli, and he's the Director of Anesthesia and Intensive Care in Brianza, Milan, Italy. My name is Annemieke Oude Lansink, and I'm an intensivist at the University Medical Center in Groningen in the Netherlands. And my moderators who will be joining me are Mirko Belliato, Director of Anesthesia in the Cardiac Thoracic ICU in Pavia, Italy, and you all know him as the chair of the EuroELSO, and Jordi Riera, who's an intensivist as well, and the ECMO program director in Barcelona, Spain. So, enough said. Hopefully you will have a nice hour or so, and I would like to ask Silvia to start off her presentation.
You are muted, Silvia.
So again, good afternoon, everybody, and thanks for being here. I'm going to discuss a bit about indications, timing, and settings for post-cardiotomy use of mechanical circulatory support. So we know what cardiogenic shock is in cardiac surgery, which is a status characterized by cardiac dysfunction resulting in organ hypoperfusion and tissue hypoxia. This can happen up to 20% of our patients in cardiac surgery. It's very difficult to recognize because, it's quite common to have an unstable patient after cardiac surgery. We have very few tools to recognize those patients who will recover, and new events can always happen after a cardiac operation. Moreover, our patients are very difficult. They have a lot of comorbidities, previous surgeries, and they come in unstable as well. So we really need to understand this word. And if you have a look at data, we notice that over time, the use of post-cardiotomy MCS is increased, and mortality has remained more or less stable, about 60% in years. In 2020, we had for the first time an expert consensus paper on this topic, giving us some directions. And in 2025, we had some new guidelines on temporary MCS in adult cardiac surgery and an expert consensus document on the concept of preemptive temporary MCS in cardiac surgery. But what is the MCS? It's a very multifaceted concept. That can happen before surgery, during surgery, or after surgery. And we might have different approaches. We can have a prophylactic approach, so we start the MCS before the patient is too unstable, or we can use a rescue approach, so when the patient is already in cardiac arrest, there's a profound cardiogenic shock. We have different goals to stabilize hemodynamics, recover organ functions, and we're going to look at these goals later in the presentation. And we have many different indications. General principles are about general concepts about indications. These are also presented in this recent guidelines. And what we can say is that we should start ECLS or TMCS before organ damage with lactates lower than 8, or in the previous consensus paper, they were said 4. when we have high and rising vasoactive inotropic score, or if we have a cardiac arrest with a bystander CPR, no ROSC in 10 minutes, and we can provide TMCS within 50-60 minutes. We have also some contraindications, so we should not start TMCS if the life expectancy is less than 1 year, if we have severe reversible neurologic damage, unwitnessed cardiac arrest, or if that's against patient and family's wishes. We have also some specific contraindication for example, axial flow pumps, like mechanical aortic valve, left ventricular thrombus, or a very large ventricular septal defect. Starting from the preoperative phase, our first goal is to stabilize the patient and gain time. So in several types of patients coming in cardiogenic shock or septic shock, or for example, with mechanical complication of a myocardial infarction, we can apply this approach to bridge the patient to an emergency operation, like an emergency bypass surgery or thrombectomy, or we can defer the operation or bridge the patient to transplant or VAT. What the concept of deferred operation is probably the one that we need to explore more. And what is this concept? This means bridging this kind of patients to an optimal organ function for the surgery, or to wait until we have a more favorable technical situation, or we want to gain time to see if the patient maybe need a percutaneous treatment instead of surgery. Organ recovery is feasible. We have some studies, not many, but we have some studies demonstrating that supporting patient before surgery allows to improve organ function and lower those risk score indicating the risk of mortality after surgery. But also brain is an organ. So sometimes we have patients coming in cardiac arrest, and this study demonstrated that waiting even more than 5 days after cardiac arrest to go to the OR is safe, and we don't have an increased risk of mortality. And this time can allow us to, for example, evaluate brain damage or neurologic status of the patient. Waiting for favorable technical situation, the typical case is when we have a septal rupture after myocardial infarction. And as surgeons, we know that when we go to the OR in an acute phase, is passing stitches in a very friable tissue means the high risk of recurrence of VSR. So we can apply some mechanical support to wait until fibrosis comes in the tissues. But we really need to think about the hemodynamic and the physiology of the patient, because based on the support that we apply, we might also increase the shunt toward the right ventricle or reverse the shunt toward the systemic circulation. In general, guidelines support the use of TMCS and VA ECLS before this kind of surgery. But it's difficult to choose, as I said, the right support for the right patient. For example, for mitral regurgitation patient, we need to unload the ventricle, reduce pulmonary pressure, and help the right ventricle to recover. So we can use an ECLS or a microaxial flow pump. If we have a mitral stenosis, we want to reduce pulmonary pressures and recover the right ventricle. Again, VA ECLS or supports like tandem heart. In pulmonary hypertension and embolism, we want to focus on right ventricle. We can use a VA ECLS, and temporary AirVAD might be contraindicated because of the risk of pulmonary hemorrhage. Then aortic stenosis, we want to stabilize the patient and go to the OR as soon as possible. Again, we can use an ECLS or a microaxial flow pump if the aortic area is more than 0.6 centimeters square. Aortic regurgitation is a very challenging patient, and when it's moderate to severe, again, we can use the setting of ECLS of microaxial flow pump. And for ischemic disease, we want to improve myocardial perfusion, unload the ventricle, and again, we can choose between these three devices. Special population is the one for transplants. Over time, we notice a decrease in the use of durable MCS as bridge to transplant in favor of an increase with, towards temporary MCS. This is mainly after the change this is in US, and is mainly after the change of the UNOS allocation system. And this brought to the declining waiting list deaths and comparable or superior survivals. Again, guidelines support the use of TMCS in patients who are deteriorating while awaiting, or to recover organ function or optimize right ventricle. But a classic approach for TMCS in cardiac surgery is when we cannot wean the patient from cardiopulmonary bypass. We know as a surgeon that sometimes might be difficult or very complex to wean this patient from CPB. We attempt several times, but we fail. And this can happen in quite a high percentage of patients, up to 50%. What to do in these cases then? It's difficult to recognize patients who have risk for failure of weaning. We can use age, for example. We know unstable patient with myocardial infarction, low ejection fraction, emergency aortic procedure, and long CPB time. They might have a higher risk of this problem. For this reason, since it's very difficult to recognize this patient, and the new guidelines provided us with a flow chart, and I will not go through all the details, but I suggest to read them carefully. This flow chart allows us to do a kind of checklist and check the parameters that can guide us to choose the TMCS. Of course, we have first to sort out the technical problems like tamponade or coronary problem, exclude patients with contraindication for TMCS, and then choose for the TMCS. Again, which type? Non-valvular surgery, usually the goal is to improve myocardial and organ perfusion and unload the ventricle. While when we have valvular surgery, this might be challenging because we want to maintain high flow through the valves to avoid ventricle and valvular thrombosis. We can consider also apical cannulation, and for mechanical valve, we might consider also the balloon pump. This indication remains the most common indication, as we demonstrated in this study, with a high mortality of 60%. And we investigated the timing when to start of intraoperative implantation of the MCS and an early implementation of the support. This goes also with the concept of protected cardiac surgery, so plan in advance and act early during surgery in those patients that we deem unstable. If we cannulate the patient in the first days after surgery, we reduce a lot of these cases, and we notice that this patient that have higher complication and mortality rate, probably because we were too late and patients were too advanced and in cardiac arrest. So probably we missed something during the OR. We should have acted earlier. So to summarize, the use of TMCS in cardiac surgery goes far beyond the classic failure to win approach. And that's because cardiac surgery is changing, and we need to adapt to this changing. We should learn how to use a preoperative TMCS to stabilize the patient. And intraoperative failure to win occurs up to 15% of our patients. We need to be prepared and plan. We need to choose the best support, thinking about the patient and machine's physiology, and we need to really think in advance. Thank you.
Thank you, Silvia, for this wonderful introduction to the post-cardiotomy field. In my introduction, I forgot to mention that for the participants, you're able to put in your questions into the Q&A field at the bottom of your screen. And during the discussion part, we will look at the questions and see which questions or which topics are most mentioned, and then we will discuss them during the discussions part. So if you have questions on Silvia's presentation, please put them in the Q&A box. Before we go into a discussion, we will first continue the presentation by Anne, and I will give the floor to her. Anne.
So I'll share my slides. Hi, everybody. So my presentation is on unloading methods, hybrid configurations, and challenging cases in post-cardiotomy ECLS. I go straight into it. So, sorry. Do you see the slides now?
We see your slides, but they're not in full screen.
Okay.
Yes.
Okay.
Yeah.
So as we know, ECLS is a great method to provide circulatory support and pulmonary support. However, ECLS leads to an increase in left ventricular afterload and stress in the pulmonary vasculature and a rightward shift of the pressure volume loop. And this can lead to problems that we encounter often in our ECLS patients, such as left ventricular distension, arrhythmias, pulmonary congestion, pulmonary edema, and thrombus formation in the left ventricle. The installation of an active unloading device, such as an impeller device, leads to a leftward shift of the pressure volume loop and a sudden decrease in pulmonary capillary wedge pressure. Studies such as ECLS shock trial have showed that there's no benefit of ECLS if no unloading is applied. And this is probably also the case in post-cardiotomy patients. Of course, these were patients in cardiogenic shock without cardiac surgery. So how do we identify left ventricular overload and the need for left ventricular unloading? So we have hemodynamic criteria such as lack of the arterial lamp positivity, which is always a great indicator. If we have an elevated pulmonary capillary wedge pressure on ECLS greater than 18, but never make any decision without echocardiography. Because we also have lack in arterial lamp positivity in case of severely depressed right ventricular function and underfilling of the left ventricle, which will also lead to decreased arterial lamp positivity without need of unloading. But echocardiography can tell us the truth. We can look at the left ventricular dimensions. We can see whether there's any stasis within the left ventricular cavity or already thrombus formation in the heart chambers. We can evaluate aortic valve opening, so how often the aortic valve opens and whether it fully opens or just partially. We can evaluate the degree of left-sided valvular regurgitations, and we can measure the VTI over the left ventricular outflow tract, which is also a good indicator. And clinical signs of pulmonary edema and refractory ventricular arrhythmia may be signs of ventricular overload. However, we should not wait until these develop, but we should act before. Studies by Schrage have shown that the timing of unloading is essential. Sorry. Timing of unloading is essential, as delay of unloading of 2 hours or more already leads to a significant decrease in survival. And this was also confirmed in this propensity matched cohort that showed the benefit of unloading without an increase in the complication rates. We have multiple options of unloading, and in the post-cardiotomy setting, we are lucky to have all the options. We can place surgical cannulas via the left apex. We can place pulmonary artery cannulas or transseptal atrial cannulas. Atrial septostomy is an option that is less efficient and of course most commonly used at least in our department, are the impeller pumps, and also there are some centers that use the intra-aortic balloon pump for left ventricular unloading on ECLS. First, we start with conservative measures because this study has shown that the indicator for pulmonary edema development on ECLS is a high ECMO output. So if we decrease the ECMO output to the necessary minimum, we can prevent, in some cases, left ventricular overload. But in many cases, this is not enough. The conservative measures are not enough. So we go for impeller. For example, the impeller CP is a smaller impeller pump, which can be placed transfemoral percutaneously. It is often used in the cath lab for protected PCI and can be used for unloading on ECMO, but is not ideal for prolonged support. Impeller 5.5, in contrast, is surgically placed either through the axillary artery or directly through the aorta, and is a fully capable temporary LVAD system and can be used for unloading in an ECMO setting as well. And in this setting, the impeller 5.5 facilitates the de-escalation to impeller only as soon as the patient does not need the ECMO anymore, and enables us to shorten the ECMO duration. Some considerations for the post-cardiotomy setting. Of course, in post-cardiotomy setting, we do not have to place the impeller via the axillary artery in all cases. We can also go for a central approach and place the impeller via the ascending aorta or also the brachiocephalic trunk. This approach can also be done via an upper hemistenotomy, for example, in patients with small vessels where the axillary artery is too small to advance the impeller. And the explant of the impeller can also be done in these cases via a minimal invasive approach with ligature of the graft without reopening the sternum. This can be conducted in the patient in local anesthesia. Passage of bioprosthetic aortic valves with the impeller can be really difficult, at least in my experience, sometimes very challenging to pass the bioprosthetic valve. But in the OR, if we are in the OR and on pump, we can advance the wire under diag vision through the valve, for example, after ABR, to avoid the problems of valve passage. In case of mechanical aortic valves, of course, we cannot use the impeller pumps. In these cases, we can use apical cannulas surgically placed. In the left picture, you see the cannula before placement. We tunnel it through the skin. In the second picture, the cannula is already inserted in the left ventricular apex. And in the right picture, you can see that this left ventricular vent line is then connected to the venous line of the ECLS circuit. And this can also be done via a mini thoracotomy approach. Another alternative to this that you can apply in patients, for example, with a left ventricular thrombus. We have published this case of a patient with a large left ventricular apical thrombus where I could not place an impeller and also not the apical venting cannula. We did this via a mini thoracotomy to access the left atrial appendage. And we put a cannula into the left atrial appendage and vented the left atrium. And this was successful, and the patient was bridged to permanent LVAD implantation with this approach. So the pros and cons of left ventricular unloading strategies on ECLS. Impeller and surgical left ventricular vents are very effective in the unloading, more effective than the balloon pump or the transeptal or atrioseptostomy approach, which are not that efficient. But the surgical vent is quite invasive. And what you also have to consider is the aortic root washout that you have in case of an impeller device, because the outflow of the impeller is directly above the aortic valve. You have some kind of aortic root washout, where in case of the surgical apical left ventricular vent, you can have stasis in the aortic root, and you can have thrombus formation in the aortic root in these cases. And because the aortic valve will not open anymore. I will skip this due to time reasons. So cannulation site choice, axillary versus femoral artery. You have to consider, of course, the different complication profiles. We have seen in axillary cannulation more strokes and more bleeding complications. And of course, in the femoral cannulation, you have more leg ischemia complications. And what you also should consider is that the afterload increase of ECLS in case of axillary cannulation is more present than in femoral cannulation. This is a nice approach suggested by the group in Berlin, where you implant ECLS and impeller unloading via the same axis, via axillary axis. And this has the advantage that you only use one vessel and have only complications of one vessel. And this also facilitates de-escalation to impeller only, because this can be done on the intensive care unit with ligature of the ECLS graft here without even touching the skin of the patient. So take-home messages are that we should use unloading in post-cardiotomy ECLS proactively. The reactive approach may be too late and mitigate the benefits of unloading. As always in surgery, this is a team decision where and how to apply the unloading. And in the post-cardiotomy setting, we have the advantage of having all the options. But this also makes the decision harder, because you also have to consider the potential complications and pitfalls. You have to consider valve prosthesis, whether you have a root replacement in place that can be pro-thrombogetic as well, whether you have a root washout with your chosen strategy. And this also affects, of course, the anticoagulation management. And you should try to go for a staged approach to first remove ECLS and de-escalate to impeller only if you're on impeller valve 5, because this allows a longer support of patients with a low complication profile. Thank you.
Thank you, Anne. There are questions coming in on the Q&A. If you have any more questions, please put them in there and we will start off the discussion. And Mirko, maybe you will join me in leading this discussion. There's a question on prediction scores. Sylvia, do you know of any scores which can predict how patients will fare during temporary mechanical circulatory support?
So actually, that's a very interesting question, and one of the most important knowledge gaps we have in post-cardiotomy MCS. Generally speaking, for VA ECLS, we have scores like the SAVE scores, which was developed for VA ECLS. And specific for cardiac surgery patient, we have the REMEMBER score, which was developed for bypass surgery. And those are specific for ECLS. In general, when we go to surgery, We use the STS score and the Euro score too as a surgeon to identify the risk of mortality of patients, but they don't predict the risk of ECLS. So we have a big gap because we don't know how to identify those patients who are going to need MCS after surgery. My suggestion, and we are also working on that project, is to identify early patients with risk. For example, patients with undergoing multiple procedures, valve patients, pulmonary hypertension patients, right ventricular failure patients, and then readapt this scoring system to each, let's say, these predictive variables to each stage of the patients, because these patients, they really change very quickly. So we're working at developing some kind of AI-based scores to give an answer. But so far, we don't really have a scores that tells us this patient is going to need an MCS, and if he gets an MCS, this is the risk that he's going to die or to the chance to be weaned after surgery. So this is a very interesting field where we're working on.
Thank you. Thank you. Thanks. We have received another question from the audience, and I have one question for Han. From the audience is, which cannulas do you use for doing a left venting? This is a question, a very technical question. So, Silvia, you are online also, and as you like. The Italian fashion, and after the...
That's a good question, because it's a bit dependent on the configuration you want to do. If you use it for unloading, you can use a smaller cannula because it's less volume. So we usually use a 20 French angled cannula, or 22 French. If you put this cannula in for a temporary LVAD, you have to consider that there's much more flow, like 4 or 5 liters. Then you have to use a larger cannula. But for unloading, for venting, we use a small cannula, like 20 French.
Silvia, do you agree?
Yeah, I agree. Same concept. You need to identify your goal, the expected flow. And if you just want to unload the patients, you just need a short cannula with a smaller diameter. And this, Anna said, angle cannula, you can, depending on how you want to tunnel the cannula as well. So you can choose an angled or a straight cannula based on where you want to tunnel the cannula. And also if the patient has, once you want to bridge a patient to a procedure, or if you access with thoracotomy or sternotomy and so on.
Thank you. If I can, Annemieke, can I make a question very, very shortly? Unloading is different from venting, in my opinion, because unloading means to reduce a workload, and venting means to, for me, means to wash out. So there are some big difference in the method for unloading and venting. Some methods, like the transseptal cannulas, is for unloading, and other is for ventings, or there are a method that can unload and venting together. So this is my question for understand better which will be my best method on my patients. Thank you. Han, can you answer? You are still mute. Okay.
Yeah, sorry. That's an interesting question. So I think, as Silvia already said, you have to know what your goal is and decide what your patient needs. But in case of the methods we usually use most, they provide both the venting and unloading.
Thank you. Silvia, you have any?
Yeah, I think that That's also a very interesting question, and I think the unloading concept should start much earlier. So with managing volumes, managing ventilations, and so on. So that's already a great part of the unloading work, and we're gonna discuss it later in the last presentation as well. And as Anna said, it depends on what your goal is. So once you set up all the basics, let's say, let me say basics, but it's not basic, strategies to unload the patients, then you can go to the active venting, like if you want to put in a microaxial flow pump, if you're sorted everything and you cannot do anything else. And you choose the methods based also on the anatomy of the patient, the degree of the endocavitary pressures, and if you have prosthetic valves, and so on. So for example, if we have a prosthetic valve, mitral or aortic valve, we really need to consider that we need to maintain the flow through the valve to avoid thrombosis. So you don't go for a method that keeps all the valves still. So it's really a dynamic process that should start quite earlier than just putting a cannula in the apex or a pump through the aortic valve.
Okay, thank you so much.
Then we'll go to the second part of this webinar with a presentation which will start on managing your post-cardiotomy patient in the ICU. So we will give the floor back to you, Silvia and Fabio.
Yes, let me share the presentation first. Okay. Okay, you should see probably the presentation now. So thanks to both of you, Annemieke and Mirko, who introduced actually this topic about ICU management. And we are going to discuss the joint ICU management. And I'm going to do that with a colleague who is also, as was presented, was also the chair of the educational chair of the European Association for Cardiothoracic Anesthesia Intensive Care. So recent guidelines, again, they support the use, the application of an interdisciplinary team all through the process of this patient. But what does this mean? This team is very complex and has a lot of personnel inside. And the problem that we often experience is speaking the same language, especially during handover. Surgeons, sometimes they don't communicate things that are obvious to them. And on the other side, intensivists, they don't ask questions. So we have a very problem of misunderstanding. So how to sort out this? We're going to go through the main points where surgeons and intensivists should discuss together. Surgeons, they like to start everything with cannulation and technical points. For example, if we talk about axillary and femoral cannulation, we always need to discuss and hand over to the intensivist how we cannulated, if we tunnel the cannulas, if we left some materials inside the wound, how was the femoral or the axillary artery, if we have a good distal flow, and if we use a distal perfusion strategy. But also, if we cannulate central, I like to describe how I put the cannula and how the flow through this venous cannula is, because it's quite different compared to the peripheral one. And when we talk about the return, sometimes we just say, oh, we cannulated the ascending aorta, but it's not always the same. We need to specify if we cannulate the ascending aorta and we use a straight cannula, we have quite a flow in the aortic root, so increased pressures in the aortic root and good coronary flow. But if we use a curved cannula or we point the tip toward the arch, then the flow goes all to the arch and we have reduced flow in the coronary arteries. Same if we cannulate the arch. If we cannulate the proximal arch, we have very good flow in the cephalic vessels. But if we cannulate the distal arch, then the brachiocephalic artery remains with a very low flow from the pump. So that's something that changes and needs to be communicated to the intensivist. Same for the chest management. We can choose to leave the chest open, cover just with gauzes, or cover with a membrane. In this case, we have a more difficult ICU care. Hemostasis might be more difficult, but when we have mediastinal edema, the heart in this case will have more space and we risk less to have tamponade or problems with the venous drainage, and we can re-enter the chest easily. If we choose to close the sternum and tunnel with cannulas, this is easier to manage the patient in the ICU, but we need to know that we risk to have supraphysiologic intrathoracic pressures, so drainage problems, so the tamponade. And bleeding is a matter of discussion often between surgeons and intensivists. When I hand over a patient, I like to specify where I put the cannula, like in this case, a venous cannula, and the relations with drains, because we want to really avoid to end up in a situation like this, where we have blood coming out from everywhere, and then we argue between surgeons and intensivists. Also because we did this surveys among a cardiac surgery unit, and we noticed that every unit is doing something different regarding protamine and anticoagulation. So how to avoid a discussion about this and be friends, let's say? We avoid this by establishing institutional protocols regarding anticoagulation. In this, guidelines help us. We have anticoagulation guidelines, again, TMCS guidelines, and position papers that support, or they even support the use of intraoperative protamine or withholding of heparin for the first 24 hours until the patient stops bleeding. Generally speaking, I like to apply this kind of flow chart. So we wait 24 hours to check if the patient is not bleeding. If bleeding is under control, less than 50, 100 cc per hour, we start heparin a low dose. If the patient is not bleeding, we go up with heparin until target ACT and APTP, and we keep monitoring the patient. Also monitoring the patient with lab tests as well. But monitoring is not only lab test. Monitoring is a more complex picture, including arterial intravenous line, pulmonary artery catheter, and so on. The setting is quite similar to a normal ECLS patient, but we need to know there are some tricks and some peculiarities in these post-cardiotomy patients. For example, I suggest to discuss the monitoring setting before closing the chest. This because surgeons can help avoiding possible complications. For example, we have free wall rupture of the right ventricle, and the right ventricle is very weak. Surgeons, they don't like to see, the intensivist going in with a pulmonary artery catheter. Or we might have some technical difficulties. We need to pass the valve, like Anna said before, for the impeller. In this case, we can work together and put the monitoring or the lines with an open chest, so the surgeon can guide the wires from within the chest and help positioning the monitoring setting. But of course, the king of the monitoring is echocardiography. And regarding echocardiography, I would like to have a Fabio discussing this topic.
So thank you, Silvia. Thank you, everyone, for having me today. And now we are going to test the real collaboration between surgeon and anesthetist or intensivist, because Silvia will be running my slides. So as Silvia was saying, I think I'm an echo enthusiast, of course, but I think that echo is absolutely central in the management of all ECMO patients, and particularly in post-cardiotomic patients. As the guidelines suggest, we should perform echo exams in a serial way. And this means to have a scan at least once daily, or if your patient's conditions require, or if your staffing permits, you should also have more than one echo per day. For sure, you should scan your patient every time you are planning any change in their management, be it unloading, or changing the vasoactive support, or starting a weaning trial, or whatever. And as we do for every patient on the ITU, when something doesn't add up to the picture that we get from conventional hemodynamic monitoring, looking into it with echo, with the morphological information, in most times clears the situation and helps us in managing the patient. So of course we can do it. Most of us are able to perform echocardiography both from a transthoracic approach or from a transesophageal approach. My personal belief is that we should go for the way that is feasible and gives us the answers that we need. Of course, as you can see on the left side, there are patients or conditions that do not allow us to scan the patient with a transthoracic approach. And on the other hand, we have, of course, a certain degree of invasiveness that can be more important in anticoagulated with low platelets patients. But on the other side, we have some conditions, and post-cardiotomic ECMO is one of these where we want to have answers that are based on posterior structures in the chest. And so we can for sure get much better images with transesophageal approach, sorry. So the surgeon was not listening, sorry. So the last topic that we wanted to address together, among the many topics that are all relevant and important in the management of these patients, the last topic that we wanted to address with Silvia was that of mechanical ventilation. And we chose mechanical ventilation because sometimes, especially in the cardiothoracic ICU, it's not, let's say, our main goal. We've seen from Anne that LV unloading is fundamental. Call it unloading, call it venting, as Mirko was mentioning before, not only for LV management, but also for pulmonary function and in turn to RV function. Going in deeper detail into mechanical ventilation, as we know, different types of cannulation can lead to different complications. And one of the complications that we all know may occur during peripheral cannulation is the so-called, as now it's fancy to say, differential hypoxemia. Of course, we have a number of tools that we can put in place when differential hypoxemia occurs, but our main goal, in my opinion, is to prevent it and to avoid its occurrence. Silvia, thank you. No, we are quite lucky in VA ECMO because as opposed to VV ECMO, the lungs of our patients are generally healthy from the beginning. However, for a number of conditions, be it surgical or patients-related or mechanical ventilation, infections or whatever, we can cause a secondary insult to the lungs and they can become very diseased. So we have to be as gentle, as kind as possible towards the lung. The guidelines basically suggest to use a lung protective approach. As Silvia was mentioning before, we may have some patients where it was not possible to close the chest in theater. And this is something that we might need to keep into consideration when ventilating and when setting ventilatory support to the patient, because transthoracic pressures may be altered. And so both mechanical ventilation and the measurements, the respiratory mechanics measurements that we may perform might be altered by these different conditions. So last year, the ASIA Journal published a survey, a very interesting survey from the Dutch colleagues. One of them is with us today, and focusing on VA ECMO, we can say that most centers adopt a lung protective approach, so they follow the guidelines. A limited but significant number of centers use ventilatory settings that are not properly protective. But the interesting thing, in my opinion, is that as I can understand from this paper, all centers set ventilation based on protocols and not on individual tailored measurements on the single patients, as you can see from the red boxes. Another thing that we should keep in mind when ventilating the patient, when setting mechanical ventilation in VA ECMO patients in general, is that, of course, as we know, we have a reduced pulmonary blood flow due to the venous drainage from the circuit, but with a conventional or also with a lung protective ventilation, the risk is to reduce CO2 in the pulmonary blood, and so to cause a significant respiratory alkalosis. So what we need to do is to always monitor end-tidal CO2, aiming at a close to normal end-tidal CO2, let's say at least above 25 millimeters of mercury, and adjust it by reducing ventilatory support, or when this is not enough, as you can see in the picture, by adding circuit dead space to promote normocapnia. So in summary, we have two main goals when setting the ventilator. The first one is to obtain a lung protection and good gas exchange. The other one is to protect the right ventricle, because this might become a key limitation when weaning the patient. So we should avoid pulmonary closure and cyclic pulmonary opening and closure. We should avoid pulmonary alkalosis. And when we move the patient to partial respiratory support and to assisted ventilation, when the patient is on ECMO, we have an extremely powerful tool in order to adapt the patient to the ventilator, and that's the gas sweep of the ECMO machine. We can adjust the respiratory effort of the patient with this tool.
So to conclude, the MCS in cardiac surgery really needs an interdisciplinary team to be managed, and we need to really work together to get the good results. There are some surgical details that might be very important for the ICU management, and some ICU intensivist details that are very important to the surgeons. Institutional protocols can really improve daily management and reduce conflicts. But we should not forget that every patient is not the same, so we really need to understand the patient's physiology. We need to discuss early and take advantage of each other's skills and adapt our ICU knowledge to the specific type of patient. As we saw, post-cardiotomy patients that have some peculiarities that we really need to consider. And collaboration is the key to success. Thank you.
Thank you.
Well, your collaboration definitely worked. You had a nearly perfect dance between a cardiac surgeon and an intensivist. Before going to the second part of the discussions, for which you can still put in questions into the Q&A, we will close the presentations with a difficult case presented by Anne. Anne, the floor is yours.
So first I want to show you this case, which was a 49-year-old patient with non-dilated cardiomyopathy who had already a cardiac surgery, a mechanical ventral procedure 12 years ago. And he was referred to our team for cardiac transplant, and he was listed for cardiac transplant because of advanced heart failure. And then we were called that this patient's deteriorating on the ICU, has a rising catecholamine support and rising lactates, and we took over this patient to our center. And the following night, this patient was deteriorating further, and he needed mechanical circulatory support. However, we really wanted to avoid VA ECMO in this patient because of the mechanical aortic valve and the root replacement, because still already the mechanical valve in aortic position is a problem on ECLS. But if there's a root replacement, there's even a high risk of aortic root thrombus formation. And yeah, this is why we want to avoid ECLS. And this patient is also not a good candidate for a durable left ventricular assist device because he also had a right ventricular failure at the same time. So we decided to put this patient on a temporary BiVAT system to bridge him to heart transplantation. And this was achieved with 4 cannulas. The first cannula was in the left ventricular apex via left lateral thoracotomy. In this case, to achieve the higher flow, we chose a larger cannula. It was a 36 French angled cannula that we used, and the return was to the right axillary artery. So this is a temporary LVAD, and we started the LVAD, and we saw that with the flow increased to 2 liters and above, this patient was not ejecting anymore and the valve was closed. So to provide a better filling of the left ventricle, we decided to put also a temporary right ventricular assist device, and we put a drainage cannula in the right groin, and the return cannula was placed percutaneously via the right jugular vein with fluoroscopy. This cannula was placed in the pulmonary artery, as you can see in this middle picture. The tip of the cannula is in the pulmonary artery, and this provides pulmonary support. This configuration also allows to put an oxygenator into the system, which we also did during the first 2 or 3 days of support in this patient. And this patient currently is stabilized and waits for a heart transplantation. I want to show you one second case, which was a 31-year-old female patient who presented with a history of flu-like symptoms, and she presented to her general practitioner and received some symptomatic therapy. But in the same evening, she suffered a syncope and was brought to the emergency department of an outpatient hospital. She was hypotensive, non-responsive to IV fluids, and the echo showed a severely depressed left ventricular function and pericardial effusion. And she was already in cardiogenic shock with a lactate of 10. But she also had a pericardial effusion, so the outside hospital suspected cardiac tamponade and did a pericardiocentesis. After which the patient stabilized for a short time. But 2 hours later, she went to cardiac arrest and underwent CPR and had a rescue ECLS implantation. So this patient was in stage E, in extremis. We were contacted that this patient has a left ventricular ejection fraction of 5%, also severely depressed right ventricular ejection fraction and mitral regurgitation, and absence of aortic valve opening on ECMO. She also was in acute respiratory distress syndrome. She had pneumonia, and we then found out that the patient had influenza. So this patient had a combined influenza ARDS and influenza myocarditis. This was a chest X-ray, and the CCT was without any pathology. And we told them to implant Impella 5.5 for left ventricular unloading, and they conducted a left ventricular biopsy at the same time. And then she was transferred to our center. And you would expect this patient has 2 machines to support her circulation. So this patient is on ECMO. You would expect a stabilization of the patient. However, unfortunately, during the transport, this patient was not well managed. She was hypertensive with a mean arterial pressure of 115, and the devices could not work in the setting. Impeller flow was almost 0, and ECLS flow was also only 1.5 to 2.5 liters. She was, of course, with this high afterload and pulmonary edema. There was no pulsatility, and she was bleeding from the cannulation side. So what we did was volume resuscitation. We managed the blood pressure and addressed the bleeding. And we also did some repositioning of the Impeller device and the venous drainage cannula. And with that, we were finally able to stabilize the patient. However, she had already some end organ damage. She was in biventricular failure, had rhabdomyolysis, kidney failure, and had the severe ARDS caused by the combination of her influenza pneumonia and the congestion and pulmonary edema caused by hypertensive episodes on ECLS. And the histopathology results also showed lymphocytic myocarditis. We then opted for placement of temporary RBAT system in the same technique that I presented earlier with transcutaneous jugular placement of the pulmonary artery cannula. And we wanted to achieve a temporary BiVAD configuration with this temporary RVAD device combined with the Impella 5.5 device. However, we were not able to create more than 1 liter flow via this PA cannula, and also the left ventricle was not filling after the start of the RVAD, and there was only a minimal rise in the impeller flow and still empty left ventricle and echo. And this was because of increased pulmonary vascular resistance, and we suspected an occlusion of the pulmonary vascular tree in this patient. And she was still in pulmonary edema, and the pulmonary edema also worsened after start of the RVAD system. So we had to decide to remove this PA cannula. And patient developed severe DIC and ARDS, underwent fasciotomy on day 4 and died 5 days after this transfer. So what we can learn from this case is that the management on ECMELA is decisive for the fate of the patient. And it's not enough to implant these devices, but we also have to manage them in the right way. Third case is a 35-year-old female patient who also had a history of flu-like symptoms and respiratory infection, shortness of breath for a few days, went to the emergency department of Peripheral Hospital, and she also had influenza, myocarditis, and also presented in cardiogenic shock. She underwent then in our center awake ECLS implantation. Lactate was not going down after that, and the left ventricular function was severely depressed, and she was not ejecting. So we had no available operating room capacity. So we opted for Impella CP implantation in the cath lab for immediate unloading. This patient also developed a pericardial effusion, which was drained. After that, positivity was improved and AV was opening. However, this patient developed on the Impella leg ischemia and also hemolysis, which is unfortunately a common complication with the Impella CP device. So we decided for an upgrade from Impella CP to Impella 5.5, and we saw in the TEE these thrombotic debris on the Impella CP catheter, which we then removed. And CT shows an occlusion of the femoral artery and external iliac artery on the Impella side, which you can see here. So patient underwent vascular surgery, reconstruction of this artery and thrombectomy. She also embolized to the brachial and radial arteries and underwent also thrombectomy there. The endomyocardial biopsy confirmed also a lymphocytic myocarditis. And this patient was evaluated for heart transplant or left ventricular assist device implantation. However, biventricular function improved in this patient, and the ECMO was explanted 9 days after implantation. 3 days later, the patient was extubated. 3 weeks after the event, the Impella was explanted, and the patient went home without any transplant or LVAD implantation 35 days after the event with a normal, nearly normal biventricular function. Thank you.
So, indeed, very challenging cases with pathology. I don't think not everyone sees on a daily basis. Jordi, would you like to start off the discussion?
Absolutely. First, saying thank you for the speakers and congratulations for this successful case, complex case. Also, Silvia, Fabio, amazing presentation, multidisciplinary, I would say also collaborative presentation. The surgeon with the bleeding situation, her weapon, and the intensivist with echo, his weapon. It seemed like Inter and AC Milan playing together in San Siro, right? That was amazing. To me, it was spectacular. But many questions from the attendees. Many of them are related with the when. The how probably depends on the experience of the team, on your possibilities. Not everywhere ECMELA is possible, right? But the when is the key point. I know that probably you would like to answer me, it depends, but I'm sorry, you can't do it, Silvia, Fabio, Anne. And I have a when for each of you, Annemieke, if I may, which is related with the questions from the attendees. First, Silvia, I think the most complex question for you. First is about ECMO indication in cardiogenic shock in the postoperative period of cardiac surgery. And there are two specific situations, Silvia, sorry. One related with non-invasive surgeries. Is there any variability in the indication compared with the habitual? And the other one is related with a certain situation which could be related with my question from to Anne. So this would be the first question for you, Silvia. And the second one is the when of winning. When is the patient ready to get a successful ECMO winning? If you would choose 1-2 parameters, please share them with me, with everybody. This is for you, Silvia. And the other one is for Anne. Anne, when should we drain? When should we unload the left ventricle? When you have showed with me to us that as soon as possible, but you never know when to do it. Do we have any parameter that you would highlight? This parameter is of paramount importance. And in that case, how do you measure the flow of this venting if you use a cannula? That's another question from a colleague. And finally, to Fabio. Fabio, those patients with closed chest, you have talked brilliantly to us about mechanical ventilation management. Is there any space for extubating some of these patients? And if it's that the case, when should we do that? And what about the pros and cons of this possibility? So first Silvia, then Anne, and then Fabio.
So thanks for these questions. A long list of questions, actually. I will try to be quick. So the first question is about minimal invasive surgery. That's a very good topic because it's coming up. More and more centers are doing, especially mitral valve or aortic valve, with minimal invasive approaches. And so if you have, also in this case, if you're in the OR when the chest is closed, and you don't have a massive bleeding so that you have to open the chest for sure to manage the bleeding, then you would go with peripheral cannulation. I wouldn't open the chest just to put a central cannula if I don't have drainage problem or specific other problems. And you can use the CPB cannulas, usually are quite good also for draining of the ECMO. If you have a complication after surgery in these patients and you have to recannulate, you have to be aware that probably you use one groin during the surgery. So if the surgeon is there, can reopen the wound and go surgical cannulation. But if you want to cannulate percutaneously because the surgery is not in-house and the intensivist is in charge of the cannulation, and you have to go percutaneously, then you have to go, I would suggest to go to the other side. And don't try to cannulate where the surgeon was, because it can be a problem. And in this case, of course, the algorithm for cardiac arrest and reanimation after cardiac surgery, I would adapt that to the fact that the sternum was closed, and just reopen only if you have a tamponade, or open the chest if you have a tamponade. By the time that you open the chest, probably if you have an ischemic problem or something that is not related to bleeding, by the time that you open the chest, probably you already cannulated the ECMO. So I would go on the pre-groin, let's say, not where the surgeon was. Then the second question was about weaning. So also for, I love really the new guidelines, because they also provide very nice flow charts about weaning. So especially for, also people who are starting, you can just print out this flow chart, and you have different cases, and you can try, follow the flow chart and do your check. I would say first parameter is to check the mean arterial pressure and the pulsatility of the patient. It's very easy thing to do. You just pass by and you check your patient in this way. Then echo, I would say ejection fraction with the trial when you go down with the flow, but I wouldn't go down with the flow too quick. So take time to go down with the flow over 1-2 days and see how this patient adapts, and use the pulsatility and mean arterial pressure and the amount of inotropes you use in those days, and then follow the flow chart or your institutional flow chart that you decided, and identify the patient you're weaning. There are different approaches if you have only VA ECLS, if you have also a microaxial flow pump, but I would say these are the rough numbers that you should check.
Thank you, Silvia. What about Anne?
The next is Anna.
Yeah, so the first question was about when to apply the unloading, sorry. So the timing. So the first question I'm always asking myself is, what was the reason why the patient went on ECLS? So was it right ventricular, biventricular, left ventricular failure? What was the problem initially? If you have a patient who went into cardiogenic shock because his left ventricular function is severely depressed, in most of the cases we opt for immediate active LV unloading, because this patient will not have enough contractile reserve to cope the increased afterload of ECMO. In contrast to that, if you have a patient who probably has a right ventricular problem with a normal left ventricular function, then we will check with echo always to make sure the left ventricle is not dilated, but most of these patients will not require left ventricular unloading on ECLS. And as I already mentioned, your best friend is the echocardiography. You can get so many information from that, whether you have stasis, distension, and what's the status of the aortic valve. And clinical indicator can also be the arterial line pulsatility, but you should never only use this as a parameter. And another important aspect, in my opinion, is that you rather unload one patient too much. So you rather go for proactive unloading, because if you encounter the problems of left ventricular distension or pulmonary congestion, then you already did some damage to the patient when you did no unloading. So rather use it proactively instead of a reactive approach. Second question was about the flow regulation in case of the left ventricular venting cannula. So this is an interesting question. You can use a flow meter, of course, on the vent line. You should always do that. And then you can try to regulate the flow with clamps. However, usually if you place the cannula in the left apex, the left ventricle will be totally empty, and the patient will not eject via the aortic valve. And in my experience, it's quite difficult to decrease this flow without compromising the line too much and risk thrombus formation in the line. You can also try to regulate the flow with the cannula size, but the volume that you need to drain for just unloading purposes is not that much, so you will achieve a completely emptied left ventricle, also with a small cannula. So you can try to regulate the flow with a clamp.
Thank you very much. And Anne and Silvia, Fabio is also answering some of the questions, typing, and now joining us for my tricky question.
Yeah, thank you, Jordi. And I think that, well, over the past few years, we've seen, starting from VV ECMO, an increasing number of patients awaken and extubated during extracorporeal support. Maybe this is still less common during VA ECMO, especially during post-cardiotomic ECMO. It has become more and more common when you implant a temporary LVAD. This is far more common because VA ECMO courses are generally shorter than VV ECMO. In my opinion, we've done it sometimes, not so frequently. When the patient is stable enough, it is not going to be moved to a medium or long-term mechanical support, but still needs ECMO. This might be a good way, just to make an example, for instance, in immunocompromised patients or so on, to reduce the risk for mechanical ventilation and then modulate their respiratory effort with the ECMO flow. And if I may, Jordi, just to add, just to continue the collaboration with Silvia, what we've seen over time regarding echo indexes of winnability, let's call them, one of the things that's coming out is, as for conventional hemodynamics, to use dynamic measurements. I mean, you perform a winning trial, you see how tissue Doppler goes, how VTI over the LVOT goes, and if the patient is coping well with the winning trial, they should increase, they should get better with the winning trial. Otherwise, it's an index that maybe you should still wait some time to win the patient.
Thank you. This is a subject where I always say we could go on for days, which we will do at the EuroELSO Congress next year in Dublin. So please join us then. I would like to thank all the speakers and my co-moderators for joining us in this session. We will close the session at this moment. If you want to reach out to some of the speakers, please do so. I think they will be very willing to answer some very specific questions you might have. This webinar will be available in next week. So if you have colleagues who would want to look back at the webinar. And the next webinar from EuroELSO will be on November 24th, which will cover the topic of accidental hypothermia. So please join us then, and good night for now. Bye.